Welcome to MedExplained. In this video, we'll walk through stroke from start to finish, what it is, why it happens, how it's diagnosed and treated as an emergency, and how a second stroke can be prevented. A stroke is an acute injury to the brain caused by a problem with its blood supply. There are two broad categories. In an ischemic stroke, blood flow to part of the brain is blocked, starving that area of oxygen and nutrients. In a hemorrhagic stroke, a blood vessel bleeds in or around the brain. Overall, roughly 4 out of 5 strokes are ischemic, and about 1 in 5 are hemorrhagic. Stroke is one of the most significant health problems in the world. It ranks as the second most common cause of death and the second most common cause of disability. In the United States alone, about 795,000 strokes occur every year, roughly 610,000 of them first-ever strokes, and about 185,000 repeat strokes. For an adult, the estimated lifetime risk of having a stroke is about 25%. That is 1 in 4 people. Ischemic strokes happen in 3 main ways. The first is thrombosis, where a clot forms directly inside a brain artery, usually on top of atherosclerosis, the fatty plaque that narrows arteries over time. The second is embolism, where a clot or other material forms elsewhere, often in the heart, then travels through the bloodstream and lodges in a brain artery. The third is systemic hypoperfusion, a general drop in blood flow such as during cardiac arrest, which can starve the brain's most vulnerable regions. To guide treatment, doctors classify ischemic strokes by their cause. One widely used system recognizes 5 groups. Large artery atherosclerosis involves narrowing of the big arteries in the neck or skull. Cardioembolism describes clots that come from the heart, very often because of an irregular heart rhythm called atrial fibrillation. Small vessel or lacunar disease affects the tiny arteries deep in the brain and is closely tied to long-standing high blood pressure. The 2 remaining groups cover other specific causes and strokes whose cause cannot be determined. Hemorrhagic strokes come in 2 forms. Intracerebral hemorrhage is bleeding directly into the brain tissue, where the blood forms a growing mass that damages the surrounding brain. Subarachnoid hemorrhage is bleeding into the fluid-filled space around the brain, most often from the rupture of an aneurysm, a weakened, ballooned section of an artery. High blood pressure is a leading cause of intracerebral hemorrhage, while other causes include head trauma, amyloid angiopathy, and bleeding disorders. The defining feature of a stroke is the sudden loss of brain function. Common warning signs include drooping on one side of the face, weakness or numbness in an arm or leg, and trouble speaking or understanding speech. A simple checklist often summarized as FAST for face, arm, speech, and time. Headache is more typical of bleeding than of a blocked vessel. In a subarachnoid hemorrhage, the first symptom is usually a sudden, extremely severe headache that patients often describe as the worst of their life. When blood flow to the brain stops, tissue begins to die quickly, so stroke is a true emergency. One of the most important pieces of information is the time the person was last known to be well. For strokes that begin during sleep, this is the moment they were last seen normal. That time determines which emergency treatments a patient can receive, which is why the central goal of the initial assessment is to rapidly identify candidates for reperfusion, treatment that restores blood flow. Brain imaging is essential, and it must come before certain treatments. A non-contrast CT scan is usually the first test because it is fast, widely available, and very good at showing whether bleeding is present. Telling a bleed apart from a blockage is critical since their treatments are opposite. MRI is more sensitive than CT for detecting early ischemic damage, and special sequences can reveal both new and very old areas of bleeding. For eligible patients with an ischemic stroke, the priority is restoring blood flow. Intravenous thrombolysis uses a clot-dissolving medication, and it improves outcomes when given within about 3 to 4.5 hours of symptom onset. For strokes caused by a large clot in a major artery, mechanical thrombectomy, physically removing the clot with a catheter device, can help carefully selected patients, sometimes up to 24 hours from when they were last known well. Eligibility for each treatment depends on timing, brain imaging, and a list of safety criteria. Alongside reperfusion, good supportive care protects the brain. The team first stabilizes the airway, breathing, and circulation. Blood pressure is handled with care. For patients receiving clot-dissolving treatment, it must be kept below set limits, while for many other patients, moderately high pressure is allowed and treated only when it is very high. Oxygen levels are kept up. Very high or very low blood sugar is corrected, fever is treated, and swallowing is checked before anything is given by mouth to reduce the risk of aspiration. After the emergency phase, the focus shifts to finding why the stroke happened, because the cause guides prevention. The heart's rhythm is monitored for at least the first day and sometimes for weeks to detect atrial fibrillation, a common and treatable source of clots. An echocardiogram examines the heart for clots and structural problems. Imaging of the arteries in the neck and head looks for dangerous narrowing, and blood tests check for contributing factors such as cholesterol levels and clotting disorders. Someone who has had an ischemic stroke or a transient ischemic attack, a brief warning episode, carries an increased risk of another stroke. Secondary prevention aims to lower that risk, and it works. A combination of treating risk factors, antithrombotic medication, blood pressure and cholesterol control, and lifestyle change substantially reduces the chance of a recurrence. Crucially, the plan is matched to the cause of the original stroke. Several measurable risk factors sit at the heart of prevention. High blood pressure is the single most important treatable cause of stroke, and for most patients, a common target after a stroke is below 130/80. Cholesterol matters too. High-intensity statin medication is recommended for patients with atherosclerotic disease to bring LDL cholesterol well down. And for people with diabetes, a reasonable goal is a hemoglobin A1C of about 7% or lower. Antithrombotic medication, drugs that reduce clotting, is a cornerstone of prevention for most patients. When the stroke is not from a heart source, antiplatelet drugs such as aspirin, clopidogrel, or aspirin combined with dipyridamole are used. When the cause is atrial fibrillation or another cardiac source of clots, anticoagulants are generally preferred instead, because they are more effective at preventing this type of stroke. The choice always weighs the benefit of preventing a stroke against the risk of bleeding. Daily habits make a real difference. Stopping smoking is strongly advised, and the excess risk falls in the years after quitting. Regular moderate exercise and a Mediterranean-style diet rich in fruits, vegetables, whole grains, nuts, and olive oil both support brain and heart health. Heavy drinkers should cut back or stop, and reaching a healthier weight improves blood pressure, blood sugar, and cholesterol all at once. To bring it all together, a stroke is a sudden, life-threatening interruption of the brain's blood supply, and it is a medical emergency where every minute counts. Rapid assessment and brain imaging separate a blocked vessel from a bleed and decide which emergency treatments can be used. And once the cause is known, steady control of risk factors, blood pressure, cholesterol, blood sugar, and healthy habits dramatically lowers the risk of another stroke. This video is for general education and is not a substitute for personal medical advice.